Welcome to Progenesis Academy. This is by far one of the most important topic I'm going to be talking about, and a topic that I feel very passionate about, which is genome editing in reproductive medicine. We know that the first attempt in genome editing in the context of reproductive medicine was done in China a few years ago. And it was done in a context that raised a lot of controversy worldwide. And the reason for that is because, number one, there was no consensus among the scientific community and among, states and non-government agencies, and the social, components was not there. There was no a discussion, public discussion on how this genome editing is going to be done and all that. So the problem that was addressed during that project was a potential immunity to HIV mutation, which is not necessarily the highest priority in medicine, and especially in reproductive medicine, because HIV is it's a general problem of infectious disease. So where are we today with genome editing, and what that example has done to science advancements or scientific advancements, and to the implementation of science and technology in reproductive medicine? It obviously has hurt a little bit the potential of being able to get a let's say a more concrete advancement in reproductive medicine. One of the obvious needs when it comes to reproductive medicine is advanced maternal age. As we know, there are patients that simply cannot conceive when they are in their 40s, and sometimes even before that. And the reason behind that is because they cannot have a chromosomally normal embryo that can be transferred to lead to a potential pregnancy. And so one of the major limitations when it comes to obtaining viable embryos is the problem of non-disjunction event, which is basically an error, a chromosome segregation in embryos at early stage, and that leads to an extra copy of a chromosome or missing chromosome, trisomies, monosomies. That those are major problems that lead to implantation failure, and sometimes to miscarriages, and sometimes to syndromes. And syndromes, when we talk about major chromosome abnormalities like chromosome 13, 18, 21, and XO. And so, but there is a chance for us, if we really understand how this chromosome segregation happen in early stage embryo and the genetic markers that encode for that process, we can potentially control for that process to happen in the correct way. And if we, and again, this is not jumping directly into the clinical application, it has to go through research. So that in countries like England, research on embryo has been granted at some point a very limited permission to do research on embryos. I think that's what the US should also initiate, mechanisms to allow investigators to do research on embryos. Why is that important? Because if we do understand how embryos segregate their chromosomes, and we fully understand the genetic markers that play a role, genetic or epigenetic, then we can potentially increase the euploidy rate in maternal and advanced maternal age. Another area of improvement is to handle mutations that otherwise would be really difficult to address. And we are talking here about mitochondrial mutations. You know that a couple that have a mitochondrial disease have to go through a three parents IVF to be able to transfer a nucleus of the mother and pass that into a recipient oocyte that has the cytoplasm and all the mitochondrial components, but does not have a nucleus. And that is it's a very invasive and high risk procedure. So imagine you're taking a nucleus from one cell and another oocyte without nucleus, and you're merging these two and adding the sperm component so that you have now a 3 parents IVF to lead to an embryo that does not have mitochondrial disease or genetics that lead to mitochondrial disease. If we are able to repair those mutations in mitochondria, and I'm not even suggesting going to embryos and modifying the embryos, you can actually just take the mitochondria out of the cell and then enhance that genetic of the mitochondria to repair the devastating mutations. Then you can put that mitochondria back to the oocyte. Even if it's diluted, even if it's a mix of mitochondria, you have a mix of affected, non-affected mitochondria, maybe a middle ground in that therapy. Or you could substitute the cytoplasm with a mitochondria that has been already conditioned not to have the mutation. Imagine if that is possible scientifically, and also there is a consensus, and there are and support from government, non-government organizations, and scientific community, how that could impact people who have genetic mutations that have no other way of having a kid without mitochondrial disease. And we know mitochondrial diseases are devastating because it doesn't affect one organ. It can go across multiple organs depending on what organ you use, the type of mutations and the mitochondrial mutations and all that. So conceiving start with a euploid embryo, then reducing the burden of genetic disease on embryos, and finally improving implantation rates. And we know implantation rate is a bottleneck. There are clinics that are not able to improve their implantation rates and pregnancy rates, knowing that they're using a chromosomally normal embryos. And the reason behind that is because we don't really understand the genetics behind the implantation. And again, if we go back to the research and then we implement the research and we have the research environment, we can understand or do research to understand what genetic markers are really important in the implantation, in the embryo implantation stage. And if we understand that, whether that is done on human or non-human, I'm not suggesting any particular formula or framework, but if we do that, if we understand the actual genetic markers or epigenetics as well for the implantation, we can potentially improve that process. We're going to be discussing all these aspects in our webinars and see if we can take this discussion to something more tangible. I would like to thank our speakers. We have a scientist, a geneticist, 2 reproductive endocrinologists, all of them committed to this discussion. Thank you so much, and I will see you soon.